Sara Mitchell, registered nurse. 7 years in the ICU at Northgate Regional. Night shift. 11 p.m. to 7 a.m. 22 beds. Level 2 trauma center. Typical mix of post-op, sepsis, respiratory failure, the occasional overdose. We run lean at night. 3 nurses, 1 charge, 1 respiratory therapist, 1 aide. That's it. That's all you get when the sun goes down. We use an electronic medical record system. Every patient has a chart. Every chart has an ID number, a name, a date of birth, allergies, diagnoses, medication orders, vital signs. The system is networked. It pulls data from the monitors at the bedside, the lab, pharmacy, radiology. Everything is time-stamped, logged, backed up to the server every 60 seconds. The system doesn't lie. It doesn't forget. It documents everything. February 9th. I clock in at 10:55 p.m. 5 minutes early like I always do. The locker room is quiet. I change into my scrubs, clip my badge to my pocket, grab my stethoscope and pen light. The hallway smells like floor cleaner and recycled air. The lights are dimmed for night mode. Just enough to see where you're going. Not enough to disturb the patients who can still sleep. I get my assignment from Linda, the charge nurse. Linda's been here 12 years. She doesn't panic. She doesn't gossip. She runs a tight unit. She hands me a printed sheet. Rooms 2, 4, 6, and 8. 4 patients. Standard load for nights. Room 2. Post-op day 1. Abdominal surgery. Stable. Pain controlled. Room 6. Pneumonia. On BiPAP. Oxygen sats improving. Awake and oriented. Room 8. Diabetic ketoacidosis. Insulin drip running. Blood sugars trending down. Awake and watching TV. Room 4. The chart says female. Age 67. Admitted at 9 p.m. tonight. Diagnosis of acute hypoxic respiratory failure. Intubated and sedated. On the ventilator. Vent settings are documented. Assist control mode. Tidal volume 450. PEEP of 8. Fraction of inspired oxygen at 60%. Sedation orders active. Propofol drip at 30 micrograms per kilogram per hour. Fentanyl boluses as needed. I print the face sheets for all 4 patients and clip them to my board. Then I walk the unit to get eyes on everyone before I take formal report. It's something I learned early. Always see your patients first, before someone tells you what to expect. Sometimes, what you see doesn't match what the chart says, and you need to know that before you inherit the problem. Room 2. Patient is asleep. Chest rising and falling evenly. Abdominal dressing dry and intact. Vitals stable on the monitor above the bed. I check the IV pump. Fluids running at 75 per hour. No alarms. Good. Room 6. Patient is awake. Sitting up at 45 degrees. BiPAP mask strapped to his face. He gives me a thumbs up when I wave. The monitor shows a saturation of 94%. Respiratory rate 22. A little fast. But that's expected with pneumonia. I make a note to check his lung sounds later. Room 8. Patient is watching a rerun of some old cop show. Picking at the dinner tray even though it's almost 11 p.m. The IV pump is beeping softly. Insulin drip running. Blood sugar fingerstick 1 hour ago was 162. Better than the 380 she came in with. I silence the pump. Check the line. Make sure it's patent. Room 4 is at the end of the hall. Past the supply closet. The door is half open. The lights are off inside. I step through the doorway and reach for the switch. But I stop. The bed is empty. Not just empty like the patient went to radiology or down for a procedure. Empty like no one has been in it. The sheets are tucked in tight. Hospital corners. Mattress flat. No pillows. No blankets bunched at the foot. The bedside table is bare. No water pitcher. No tissue box. No call button within reach. The ventilator is off. Screen dark. Breathing circuit disconnected. Hanging loose on the side of the machine. The IV pole next to the bed is empty. No bags. No pumps. No lines. The monitor above the bed shows a flat line. No waveform. No numbers. Just a green horizontal line across a black screen. The room smells like disinfectant. That sharp, chemical smell we use when we turn a room after a discharge. But the chart says this patient was admitted 2 hours ago. There hasn't been time for a discharge and a turnover. I stand in the doorway for a few seconds, trying to make sense of what I am seeing. Then I walk back to the nurse's station. Linda is sitting at the desk, typing into the computer, finishing up her notes from the shift. I set my board down next to her and pull up a chair. Linda, is the patient in room 4 transferred? She doesn't look up. No transfers tonight. Discharged? No discharges either. Why? There's no one in the bed. She stops typing. She looks at me, then looks at her screen. She clicks through the chart. It says she's there. Jane Holloway, 67. Admitted at 9 p.m. with hypoxic respiratory failure. Dr. Patel admitted her. Linda, I'm telling you. The bed is empty. The vent is off. There's no IV. The monitor isn't on. She frowns. She clicks through the flow sheets. The section where the vitals auto-populate from the bedside monitor. Heart rate 72. Blood pressure 112/68. Oxygen saturation 96%. Respiratory rate 14. Ventilator assisted. Temperature 37.1 Celsius. It says she's stable. Vitals are updating every 5 minutes. She points at the timestamp column. Last update was 3 minutes ago. Linda. The monitor is off. I'm looking at a flatline. She stands up. She doesn't say anything. She just walks with me down the hall, past the supply closet, to room 4. We both step inside. The bed is still empty. The ventilator is still off. The monitor is still showing a flat line. Linda walks to the bedside. She taps the monitor screen with her knuckle, like maybe it's frozen or glitched. Nothing changes. She checks the ventilator, unplugs it, plugs it back in. The screen stays dark. She looks at the empty IV pole, then at the bed, then at me. She pulls out her phone and takes a picture of the empty bed. Then she takes a picture of the monitor. Then she walks out of the room without saying a word. I follow her back to the nurse's station. She sits down and pulls up the chart again. This time she goes deeper. Admission note. Orders. Labs. Imaging. Everything is there. Everything looks legitimate. Admission note. Time stamped 9 p.m. Written by Dr. Raymond Paddle. 67-year-old female with 3-day history of progressive dyspnea and fever. Presented to Ed with hypoxia. Oxygen saturation 78% on room air. Improved to 92% on non-rebreather mask. Chest X-ray shows bilateral infiltrates consistent with pneumonia versus ARDS. Intubated in Ed for airway protection and respiratory support. Admitted to ICU for mechanical ventilation and sepsis workup. Orders. Ventilator settings. Sedation. Antibiotics. Labs every 6 hours. Chest X-ray portable. DVT prophylaxis. Stress ulcer prophylaxis. Standard ICU admission orders. Nothing unusual. Linda scrolls to the flow sheet section. Vitals have been documented every 5 minutes since admission. Heart rate. Blood pressure. Oxygen saturation. Respiratory rate. Temperature. All within normal limit. All auto-populated from the bedside telemetry system. Except the bedside monitor is off. Linda picks up the desk phone and dials an extension. 4 rings. Then someone picks up. This is Linda. IQ charge. I need the house supervisor up here. We have a situation. She hangs up. We sit in silence for 10 minutes. I check my other rooms. Room 2 is still asleep. Room 6 is still stable. Room 8 is finishing the last of her dinner tray. At 11:20 p.m., Kevin arrives. Kevin's the house supervisor. Mid-50s. Former air nurse. Been in administration for the last 8 years. Has wearing a polo shirt with the hospital logo and a set of keys clipped to his belt. He doesn't look happy to be here. What's the problem? Linda gestures to the screen. Room 4. Patient admitted at 9 p.m. Intubated. On the vent. But there's no one in the bed. Kevin looks at the screen. Then looks at me. Show me. We walk down the hall. Kevin steps into room 4. Looks at the empty bed. Looks at the dark monitor. Looks at the idle ventilator. He walks to the bedside. Checks the wristband holder. Empty. He opens the bedside drawer. Nothing. He checks the bathroom. Door open. Lights off. Empty. He walks back to the nurse's station and logs into the system with his administrator credentials. He pulls up the admission record. Patient name. Jane Holloway. Date of birth. March 14, 1958. Social Security number. 523-64-8197. Address. 412 Walnut Street. Apartment 3B. Insurance. Medicare Primary. Blue Cross Secondary. Admitting physician. Dr. Raymond Patel. Pulmonology. Admission time. 9 p.m. February 9, 2025. Kevin picks up the phone and calls Dr. Patel's answering service. 2 minutes later, his phone rings. He puts it on speaker. This is Dr. Mehta. I'm covering pulmonology tonight. You paged? Kevin identifies himself. Do you have a patient named Jane Holloway, admitted to ICU tonight? There's a pause. Typing sounds in the background. I don't see that name on my list. Let me check the admission log. More typing. No. Nothing. I admitted 2 patients today. One this afternoon for a UCPD exacerbation. One around 5:30 for a pleural effusion. Neither of them is named Holloway. And Dr. Patel didn't admit anyone tonight. Has off service until Wednesday. The chart shows he admitted a Jane Holloway at 9 p.m. tonight. Intubated. ICU. Acute hypoxic respiratory failure. That's not possible. He wasn't even in the hospital tonight. Hez at a conference in Chicago. Kevin thanks him and hangs up. He opens another system, the billing interface. He types in Jane Holloway's name. An account pulls up. Active. Charges have been posting since 9 p.m. ICU room charge. $240 per hour. Ventilator rental. $150 per day. Sedation medications. Propofol. Fentanyl. Lab draws. CBC. BMP. Abdeg. Chest X-ray. Portable. Single view. Total charges so far. $2,160. Kevin clicks on the radiology tab. There's an order for a chest X-ray. Portable. Room 4. Ordered at 9:15 p.m. Status. Completed. He clicks on the image. It loads. It's a standard portable chest film. AP view. The image is labeled with the patient name. Jane Holloway. The date. The time. The room number. The lungs show patchy bilateral infiltrates. Ground glass opacities in both lower lobes. Consistent with pneumonia. Pulmonary edema. Or ARDS. There's an endotracheal tube visible. The tip positioned about 2 centimeters above the carina. Textbook placement. Kevin zooms in on the metadata strip at the bottom of the image. Accession number 2509-202-5037. Technician initials. GL. Ordering provider. Patel. Raymond. Everything looks legitimate. But the patient doesn't exist. Kevin opens the lab system. Blood work was ordered at 9:30 p.m. Complete blood count. Basic metabolic panel. Arterial blood gas. Results are posted. Time stamped 10 p.m. CBC. White blood cell count 14.2. Elevated. Hemoglobin 12%. Normal. Platelets 220. Normal. BMP. Sodium 1/40. Potassium 4/1. Glucose 103. Creatinine 0.9. All normal. Abgay. PI 736. PSA 2042. PA 88. Bicarb 24. Mild respiratory acidosis with metabolic compensation. Consistent with a patient on a ventilator. Kevin clicks on the specimen tracking log. It shows the sample was collected in ICU room 4 at 9:30 p.m. Labeled with patient ID number 8765432. Transported to the lab at 9:40 p.m. by ICU aide. Received and processed by Lab Tech GM at 9:55 p.m. Kevin picks up the phone again. He dials the lab. Someone picks up on the second ring. Lab. This is Gina. Gina. This is Kevin. House supervisor. Did you process labs for a Jane Holloway tonight? IQ room 4? Hold on. Keyboard clicking. Yeah. Around 9:30. Maybe 9:40. Standard ICU panel and a blood gas. Why? Is there a problem? Do you remember who brought the sample down? I think it was one of the aides. I didn't really look at who dropped it off. We were slammed tonight. 4 traumas came in right before that. The sample was labeled correctly. So I just ran it. Is there any way to verify the sample actually came from a patient? Not really. No. I mean, unless there's something wrong with the specimen? Hemolyzed. Clotted. Insufficient volume. Something like that. But this one was fine. Good draw. No issues. Kevin thanks her and hangs up. He sits at the desk and stares at the screen for a long time. Linda and I don't say anything. We just wait. Finally, Kevin speaks. Print the entire chart. Admission note. Orders. Flow sheets. Labs. Imaging. Billing. Everything. Put it in a folder and lock it in the medroom. I'll notify risk management in the morning. He looks at me. Keep your other 3 patients. Do not chart anything in room 4. Do not go in there unless I tell you to. He looks at Linda. Document the discrepancy in the shift report. Note the time you discovered it. Who was present? What actions were taken? That's it. Then he leaves. I work the rest of the shift. Midnight rounds. Check vitals. Reposition patients. Assess pain. Document. 1 med pass. Antibiotics for room 6. Insulin adjustments for room 8. 2 a.m. blood sugar checks. 3 a.m. vitals. 4 a.m. lab draws for morning panels. 5 a.m. patient assessments. Charting. Preparing for shift change. My other 3 patients are stable. I don't go into room 4. At 5:30 a.m. the monitor alarm goes off. It's room 4. I look up at the central telemetry board mounted on the wall above the nurses' station. The board shows live vitals for every bed in the ICU. Room 4's panel is flashing red. Heart rate. Wow. 42. Blood pressure. 92/56. Oxygen saturation. 83%. The alarm tone escalates. 2 beeps. Pause. 2 beeps. Pause. Critical low heart rate. Critical low oxygen saturation. Linda is staring at the screen. Marcus, the respiratory therapist, is staring too. The numbers keep dropping. Heart rate. 38. Saturation. 79. Blood pressure. 86/51. Then 74%. Marcus stands up. Someone needs to go in there. Linda looks at him. Her voice is flat. There's no one in there. Marcus. The monitor says there is. I stand up. I don't say anything. I just walk down the hall. My stomach feels tight. My hands are cold. I push open the door to room 4. The bed is still empty. The sheets are still tucked. The monitor on the wall is still dark, still showing a flat line. The ventilator is still off, still silent. There's no sound in the room except the faint hum of the HVAC and the distant beep of another patient's RV pump down the hall. I stand in the doorway for 5 seconds. Then I walk back to the nurses' station. The central telemetry board is still flashing red. Heart rate. 131. Saturation. 68%. Blood pressure. 70/40. Then the waveform goes flat. The alarm changes tone. One long, continuous, high-pitched beep. Is systole. No pulse. No heartbeat. The code bell doesn't ring. No one moves. We all just stand there, staring at the screen. After 10 seconds, the alarm silences itself. The screen goes blank. The room 4 panel on the central board turns gray. No waveform. No numbers. Just the words lead off in small white letters at the top of the panel. Lead off. Electrodes disconnected. No signal. At 6 a.m., the day shift starts arriving. I hear voices in the hallway. Footsteps. The sound of lockers opening and closing. I give report to the oncoming nurse. Amy, someone I've worked with for 3 years. I tell her I have 3 patients. Room 2. Room 6. Room 8. I give her their diagnoses, their overnight course, their pending labs, their expected trajectories. She takes notes, asks a few clarifying questions, nods. She doesn't ask about room 4. I don't mention it. At 7 a.m., I clock out. I walk to my car in the parking garage. The sun is just starting to rise. Pale gray light filtering through the concrete pillars. I drive home, shower, eat a bowl of cereal standing at the kitchen counter, and fall into bed. I sleep for 6 hours. When I wake up, I check my phone. No missed calls. No texts. I eat lunch. Leftover pasta. Reheated in the microwave. And get ready for the next shift. I'm back at the hospital by 10:30 p.m. Room 4 is occupied. Real patient. Real chart. Real diagnosis. 72-year-old male. Post-cardiac arrest. Status post-successful resuscitation in the ED. Now intubated and sedated. On the ventilator for airway protection. I take care of him for the next 3 nights. He wakes up on day 3. He extubates on day 4. He transfers to the step-down unit on day 5. I check the electronic medical record for Jane Holloway. I search by name, by date of birth, by social security number. Nothing. No active chart. No archived file. No discharge summary. No billing record. It's like she was never here. I ask Linda if she remembers the night of February 9th. The patient in room 4 who didn't exist. She looks at me for a long time. Then she says, I remember we were short-staffed that night. I remember it was a quiet shift. I ask Marcus, the respiratory therapist. He says he doesn't remember anything unusual. I pull up my own documentation from that shift. My flow sheets show 3 patients. Room 2, Room 6, Room 8. Room 4 isn't he listed. It's like I never had a 4th patient. But I printed the face sheet. I stood in that room and looked at an empty bed. I watched the central monitor show vitals that couldn't exist. I watched it flatline while the room stayed empty. 3 weeks later, I'm restocking the supply room at the end of the hall, near room 4. I'm counting the 4 start kits, logging inventory on a clipboard. The door to room 4 is cracked open about 6 inches. I hear something. The ventilator. That rhythmic hiss and click. Inhale. Pause. Exhale. Pause. The sound of the machine cycling. Delivering breaths. I stop. I listen. I hear the monitor beeping. Slow. Steady. The regular pulse tone that means a stable rhythm. I set the clipboard down. I walk to the door. I push it open slowly. The bed is empty. The sheets are tucked. The monitor is dark. The ventilator is off. I stand in the doorway for 10 seconds. Then I close the door and walk away. I don't work in room 4 anymore. If it's in my assignment, I ask Linda to switch me with someone else. If she asks why, I say I have a superstition. She doesn't push. She just switches me. The system still updates room 4 sometimes. During the night shift, vitals will auto-populate for 10, 15 minutes. Heart rate, blood pressure, oxygen saturation. Then stop. The panel goes gray. No one charts on it. No one talks about it. I don't have an explanation for a chart that existed for 8 hours. Generated lab results. Ordered imaging. Billed for services. And logged a code. All while the room stayed empty. I just have the printout I kept. The face sheet. Jane Holloway. Date of birth March 14, 1958. Admitted February 9th at 9 p.m. for acute hypoxic respiratory failure. Room 4. And a monitor that still believes someone is in there. Some nights, when I walk past room 4, I slow down. I listen. I check the central board to see if the panel is updating. It is, sometimes, unresolved.